Good evening, States members, healthcare professionals and residents of Jersey. It's wonderful to see so many of you here tonight for this event, which is hosted jointly by the Jersey Dying Well Group and our Duty of Care Jersey. We are joined tonight by a wonderful selection of speakers who are experts in their field and a number who are internationally renowned. Sonia Socher of The Observer wrote only earlier this week, "There are no higher stakes than ending a life. On the face of it, assisted suicide might sound like a limited shift in the law, but when you start probing its limits, it quickly becomes evident how difficult it is to draw a distinction between what is and isn't permitted." I will now hand over to our first speaker, Baroness Finlay of Llandaff. Ilora is a doctor and professor who became a life peer in 2001. She established the Marie Curie Hospice in 1987 and is recognised as the founder of palliative care in Wales, amongst many other achievements. Ilora.
Thank you very much. And States members, ladies and gentlemen, can I first thank you for inviting me to come back to this lovely island of yours. And as my nephew is marrying into a family here, I think I'm going to be back quite a lot, actually. But there we go. So I hope that you don't object. I hope that I'm declaring all my interests on this slide. I'm not going to run through each of them, but obviously I have the privilege of being able to sit in the House of Lords. And I was on the Select Committee, chaired by Lord Mackay of Clashfern, who was the longest-serving Lord Chancellor, to look at the assisted dying bill, and we've got a 3-volume report. You can find that on the House of Lords website. And we looked into the issues in great detail, including visiting countries where the law has changed. I know that you've had your own inquiries here, and a point that I want to make, and I will be emphasising through our talk, is it's been really interesting how in the last couple of years, and even in the last couple of months, a lot of new evidence has emerged from places that had changed their law, and new concerns have arisen. I think that there are 3 key questions. First of all, does the existing law need to change? In other words, if you change it, what you replace it with, is that going to be better for the whole population? As a legislator, I have to make sure that anything that I'm voting for protects the whole population, not just those who are most outspoken. And the next question is, would a bill as proposed, and as we've seen also in the UK Parliament, would it safeguard people who are vulnerable in the population, or would it put them at greater risk? And I think the question really is, how safe is safe enough? Lord Faulkner once on the Today programme said that he accepted that there would be errors and mistakes. And I think when somebody's life has gone, that's a pretty difficult situation to live with. And then the last question really is whether assessing people for lethal drugs is a role for doctors, and in particular in a community like yours where you've already got a shortage of healthcare professionals. Can you take people away from doing clinical care to do the assessments and manage this? And are the assessments within the competencies? Let's be clear what we're talking about. We're talking about either physician-assisted suicide or physician-assisted suicide and euthanasia. Now, 96% of the world's population have not opted for assisted dying. And it's worth remembering it has been turned down in many places in the world. So that's a little-known fact, but it's important to keep it in perspective. It is the wealthy West nations, in a way, that have gone down this road, and I'll give you evidence from there. But actually, what does it involve? Well, assisted suicide is where the patient takes the drugs. This isn't one pill that you take and you die rapidly. So secobarbital was originally used in Oregon, and I just typed out what the label says because it's difficult to read. Just before ingestion, dissolve the powder from 100 capsules in warm liquid and drink as a single dose. It actually tastes absolutely filthy. It's extremely bitter, and you need a big tumbler full because it's not terribly soluble. And you also need to take an anti-sickness drug beforehand because otherwise you'll vomit it back. But actually the shortage of barbiturates, they move to different mixtures. And again, this isn't just one tablet. This is 100 tablets of diazepam, around 50 tablets of digoxin, about 50 tablets of amitriptyline, and then some morphine sulfate liquid as well. So you're talking about 200 tablets that you've got to get down. You can crush them up and mix them in jam, but it's a pretty horrible sludgy mixture. The problem is that there has been no data on how these mixtures actually work, and effectively this is human experimentation. There have been no trials. With euthanasia, you inject a solution, and these are really the main ingredients in a euthanasia solution. Currently, the one that seems to be used most is propofol. Are there any anaesthetists in the room? No? Okay, well, let me try and explain then. It's a fast-acting anaesthetic. It's the thing that you get given to put you to sleep when you're going in for an operation, but it distributes extremely rapidly in the body. So that's why some people, you give them the dose, they go off to sleep, but they start to wake up again really quickly, and you have to give them 2 or 3 more doses to keep them under while you're putting a tube down and all the other things, getting them ready for surgery. But the one that's the most worrying is if they don't die with that injection, you then add pancuronium, which is a curare-like substance that totally paralyses you. You can't move a muscle. You therefore stop breathing. You will look as if you're peaceful because you can't move a muscle, and you die of asphyxia. Now, the difficulty, of course, is that this was a mixture that's been used in lethal executions in America, but actually has been abandoned. And there was one paper published suggesting that up to 80% of people may have regained consciousness to a certain degree before they actually died, but to the observers of the execution, they looked as if they were peaceful because they couldn't move a muscle. No eye movements, nothing. And that's the same as happened to women during caesarean section, where they were aware, they could hear everything going on, feel everything, but the anaesthetist who was there didn't realise that they were actually awake because they were totally paralysed and being ventilated. None of these drugs have ever been scientifically evaluated, not for assisted suicide or euthanasia. And before coming out tonight, I checked up with one of my colleagues who's just done another literature search and cannot find a single regulatory body that has looked at how these drug combinations work, other than that they stop you breathing and you die of asphyxia. I've written a book with a colleague of mine. It's a short paperback, and we tried to look at all the different issues. And I want to point out that the word safeguards can be misleading because they're really qualifying criteria. For something to be a safeguard, it has to be absolutely verifiable, and if it's breached, you need a default system which always clocks in. But actually, with the criteria that are proposed, that doesn't apply. You matter, everybody matters, and people need choices in life, but they need real choices. They need choices about their care, they need choices in what they're doing. They don't need necessarily to be denied the care that they need, and therefore the only so-called choice left to them is to opt to die. Here, in your proposals, you've basically got 2 routes. One is for people who are thought to be terminally ill. The other one is for people who are not terminally ill, who've got a chronic illness. In the time available, I'm not even going to address that group because there are a huge number of problems with trying to address that group. I'm just going to address the first group, which are the terminally ill. So what are the pitfalls in the safeguards so-called, or the qualifying conditions? Well, the only thing that's verifiable really is age. The rest aren't, and I will go through each of these in turn. But the one I do want you to focus on a bit is the power differential in the doctor-patient relationship, because patients believe what we as doctors tell them. And I will now go through some of the issues. So somebody is terminally ill. Well, we know from postmortems that actually there's a 30% error in what's written on the death certificate. And we know that there's a complete misdiagnosis of the illness in 5% of people. That's post-mortem data from the Royal College of Pathologists. As for prognosis, you cannot predict 6 months to live. We were told on our select committee, medicine is a probabilistic art. When death is thought to be 6 or 8 months away, it's pretty desperately hopeless as an accurate factor, and the scope for error can extend into years. Even with the Liverpool care pathway, which has become discredited when people were thought to be in the last 48 hours of life, 3% of them improved. What about mental capacity? Well, it looks simple when written down, but actually people are often cognitively impaired because of their illness, because of their medication or metabolic changes. And there was a study done in Oregon which showed that 1 in 6 people who were cleared for physician-assisted suicide had an undiagnosed, untreated clinical depression that could have been treated. And of those that went on to end their life, it went up to 1 in 3. So they had a reversible depression that had been missed by everybody. But the most worrying is voluntariness. There are different types of coercion that go on. There's internal coercion. And it's important to remember that a wish to live and a wish to die fluctuate. People are often frightened of being a burden on their family, of losing autonomy. The Oregon data shows that over 90% are frightened of losing their autonomy. Over 50% are frightened of being a burden on the family. Pain or fear of future pain is much lower down the list. So although you'll be told it's about having a painful death, no, pain is something that you manage and treat, and it can be complex. That's why there's specialist services. But the other is external coercion. Coercion in families. That may not necessarily be malicious, but it may just be that everybody's got fed up looking after somebody, they're exhausted, that the money's running out, the care costs are going up, the financial pressures are there. And what about having a clear and settled intention? Well, the data from Hourglass, which did a survey recently and published it, was about abuse. And 1 in 5 of people over the age of 65 have been affected by abuse. 83% of it goes on in their own home, behind closed doors. It is not known about to anybody looking after these people. Often the abused person doesn't say that they're being abused. And most of it is in the sectors that doctors wouldn't know about anyway. It's financial, it may be neglect, and it may be psychological. When a patient, 8% have been physically abused, and the person may present with bruises, but they often will say, oh, well, I fell over in the kitchen, or I walked into a cupboard or something, because they're covering up for their relatives. So let me just illustrate to you a patient who had been told that she had a 2 to 3 month prognosis, she was in a hospice and she was dying, and she just wanted to get it over with. Well, 4 years later, having gone home, having had some palliative radiotherapy, all her pain control well sorted out, she said, when she was in bed at home, I am at the end of my life, in bed and unable to do, but able to receive and find an unexpected serenity in receiving. A week ago, I wanted to die, exhausted by an existence that seemed to become hollow and futile, fearful of disrupting lives of those I loved so dearly. My wish to die resurfaced, yet my ability to live resurfaced too. So what about the thing called autonomy that is spoken about? I told you that a driver is fear of losing autonomy. What is it? Well, we have to be able to make a choice, but it has to be a real choice. It has to be between two things that are actually equal, not that it's so skewed that you've really only got one option. And we have to be able to communicate what we want. But autonomy can only exist if it's respected, and one person's cannot override another. It does not mean I want, therefore I get. Autonomy is relational. The way that we live and the way that we die affects those around us. And I just want to tell you briefly about a boy I met whose mother had gone to Dignitas. He was in his early 20s, unable to form relationships with people. And he said he felt his love was not good enough to sustain his mother and that she had to go and end her life. And it was a failing in him. And if he couldn't love his mother enough to keep her alive, how could he ever love anybody else enough? And so he kept on breaking off relationships because he was so deeply traumatized with the guilt that he felt over it. And what is dignity? Well, it was defined as having a sense of personal worth, and that's a quote from Cicely Saunders. And it is about feeling valued. But what is driving these requests? And this is new data that's just come out. Holland is the most liberal country in the world, and 42% of patients there have at least one unresolved symptom. So changing the law and having euthanasia doesn't mean that you get better symptom control. 42% is quite high for unresolved symptoms. What about in Canada? Well, interviewing those who provided medical assistance in dying, and this is a study that's only just been published. In their conclusion, the author said, in the cases where patients had unmet needs, these were usually related to loneliness and poverty. This is not about unrelieved symptoms and pain. The main driver is social factors there. And at the time in Oregon that they passed their law, most of the patients were privately insured. But something has changed, we don't know quite what, and now it's flipped, and now the majority, 2/3, are actually in the poor section of society on state-aided healthcare. So quite what's going on, we just don't know, but suggests socioeconomic pressures in the society. Pain, as I said, is a symptom that we can get on top of, but you don't just treat the physical, you treat the whole person, and Carol is going to deal a bit with that, I think, in her talk. I had a patient who came in on 1 gram of morphine, but when we untangled her emotional and social distress, and it actually turned out she was being abused at home and had been for years, her morphine requirements fell to 30 milligrams a day. So quite a big change, and that was because her pain experience was made so much worse by her emotional distress. So what happens as you die of progressive, normally what happens if you're dying of disease? Well, people seem to think that you're rolling around in pain or something terrible happens, but actually nearly everybody just becomes increasingly tired. They lose their energy. They become drowsy, weak, slip into a coma. Their breathing slows. It may become bubbly and sound bubbly, and it may be irregular. That's part of the dying process. It doesn't mean that they're distressed. By then, they're usually unconscious, can hear what's said to them, and their colour changes, their pulse weakens, their heart stops, and their breathing stops, and they die. Sometimes a few moments after you think they've taken their last breath, there's one more, which can come as a bit of a shock to family who are sitting there, but actually they just slip out of the world peacefully and gently. So what's happened to the numbers of reported assisted deaths each year? This is data from the official reports. Okay, so this is all published public domain data. The blue line at the bottom is Oregon. It has crept up. It's a small population and it has crept up, but they can't have euthanasia because the federal law in America overrides state law and does not allow euthanasia. So that legal situation would not apply here because you don't have that legal structure. Belgium, we know only about 50% are reported, so that line would probably be much higher, but I'm only going on the officially reported data. The Netherlands is the yellow line, but look at Canada, that's the red line. There's something going on there which is a really exponential rise. Is this only people deemed to be dying? Well, no. This was a girl in the Netherlands who had been abused in childhood. She then became a self-harmer, profoundly depressed, and on grounds of her suffering, and she had lots of physical symptoms as well as her psychiatric suffering, she had euthanasia at the age of 29. I have a difficulty with the victim being euthanized and the perpetrator of her abuse during childhood going free, but that's the way it worked. So what about the numbers? Well, if we look at what I've done here is put the population in the different areas, their numbers of deaths, and calculated what that would mean for Jersey with your population. Vancouver Island is worth looking at because, like you, it's an island. It has a much bigger population. And there, 1 in 13 of all deaths is by assisted suicide or euthanasia. So that would translate overall to about 30 to 50 deaths in Jersey each year. Now, somebody asked me earlier on today how long the medical assessments would take. And I had dramatically underestimated, because actually the data that we've got coming from Australia is that it takes 60 hours per patient to do the medical assessments alone. That is before you involve nurses, pharmacists, and so on. Now, on those numbers, if we work it out for about 45 patients a year, that would be 630 medical sessions lost from clinical care, taken over to do assessments for assisted suicide and euthanasia. And that's a rather large number. And I think in a place where you've got such a shortage, 15% shortage of GPs and so on, you really do have to think about how you would address it.